Hello, I'd like to thank the organizers as well for inviting me to present our data from the ABCDS study. Today I'll be talking about executive function decline and regional beta amyloid accumulation due to Alzheimer's disease and Down syndrome. Down syndrome is the most common chromosomal disorder in the United States and the most common cause of intellectual disability. People with Down syndrome typically have intellectual disability in the mild, moderate, or severe range. It occurs in 1 in 700 births in the United States and approximately 1 in 1,000 births worldwide. About 250,000 people in the US have Down syndrome and over 6 million people worldwide. The term was first coined in 1887 by John Langdon Down. And in 1959, a French geneticist named Jerome Lejeune discovered that Down syndrome was caused by a triplication of chromosome 21. Since we are talking about Alzheimer's disease, I wanted to briefly go over the amyloid cascade hypothesis, which is the dominant model of Alzheimer's disease pathology. And it posits the central role of beta amyloid protein. Amyloid is regulated by the amyloid precursor protein, also called APP. And as you can see in the graph, APP sets off a chain of different processes that ultimately leads to plaques, and the plaques are believed to cause further neurodegeneration as well as cell death. Aduhelm, which is the most recent drug developed and approved by the FDA, is a monoclonal antibody designed to clear or break up beta amyloid plaques in the brain. So the reason for studying Down syndrome and Alzheimer's disease is because people with Down syndrome have high risk for developing it. The APP gene is on chromosome 21. As a result, people with Down syndrome have a 1.5-fold overexpression of APP. And beta amyloid deposit begins in infancy and accumulates across the lifespan, rather than only in adulthood, as in the general population. And as you can see from the pictures on the left, plaque formation is already evident by 31 years of age, and by 54 years of age, you can see how prevalent it is. So people with Down syndrome also develop Alzheimer's disease dementia much earlier. Senile plaques and neurofibrillary tangles are already prevalent in late childhood and early adolescence and throughout their 20s. And then there is a significant rise in production and accumulation during the 30s. And by age 40, virtually all people with Down syndrome will have sufficient neuropathology for AD. The progression of AD biomarkers is also similar in Down syndrome as it is to the general population. Thus, it serves as a good model for Alzheimer's disease, generally speaking. This model, created by Jack and colleagues, is well known in the literature, and it shows how beta amyloid is the first of the neurodegenerative processes to occur, followed by tau-mediated dysfunction, changes in brain structure, and then clinical symptoms, with memory being the first to show decline, as well, then followed by other types of cognitive and functional changes. In this model, by Ballard and colleagues, you can see that in Down syndrome, the pathological changes are similar and occur in the same order. However, they begin much earlier in age. And the duration of disease progression is also much shorter. amyloid changes are already believed to be evident by age 20, and clinical changes become apparent by age 30. And this was when there's also a dramatic increase in plaque formation, followed by the development of neurofibrillary tangles. And most people with Down syndrome will develop clinical dementia by their late 60s. In our previous work, we found that beta amyloid in the brain was significantly related to disease status. Alzheimer's disease status was determined through a consensus conference process that involved an entire team, including neurologists, neuropsychologists, and senior staff who were experienced with the disorder, diagnosing collectively people, all the research participants. When we compared the group with dementia to the group with mild cognitive impairment, or what is considered the prodromal phase of the disorder, we found that there was increased amyloid burden in predominantly frontal regions. And as you can see here, comparing the dementia group to the group with no dementia, there was significantly more amyloid in multiple regions throughout the brain, including the temporal, parietal, and occipital lobes. Therefore, these results suggest if during the prodromal phase, an accumulation of amyloid in the frontal region was already evident, we hypothesized that clinical manifestation of Alzheimer's disease or in the early stages would include changes in executive function. So to briefly explain what executive function is, it refers to a collective set of abilities that are quite complex. It is not one particular skill. It involves planning, focus, working memory, managing emotions, self-monitoring, cognitive flexibility, inhibitory control, problem solving, and many others. In the general population, the neural correlates of executive function are known. They include the anterior cingulate cortex, anterior insular cortex, dorsolateral premotor cortex, dorsolateral prefrontal cortex, inferior frontal junction, and posterior parietal cortex. Together, this integrated network is known as the cognitive control network. So there were a couple of reasons why we want to look at executive function in Down syndrome. First, decline in executive functions is associated with normal aging due to neuroanatomical changes. Also, as I mentioned before from our previous work, as well as from other studies, decline in frontal lobe functions, including executive function, have been proposed as a key indicator of Alzheimer's disease and Down syndrome. However, for a number of reasons, we chose to compare executive function outcomes to amyloid burden, because people with Down syndrome have abnormal brain volumes throughout the lifespan, even in the absence of Alzheimer's disease pathology. In addition, atrophy occurs during the normal aging process. So many investigators have found, using the Pittsburgh compound, shortened for as PIB-B, that brain structure and cognitive performance is linked to buildup of beta amyloid in Down syndrome. Participants with no PIB binding, meaning with no discernible levels of beta amyloid buildup, have stable brain volumes and cognitive performance over time. And our colleague Segan Hartley and her team also found that increased amyloid load can be demonstrated to result in worsening performance on tests involving memory, visual spatial skills, and visual motor. And in this chart here, you can see the blue lines represent those who have positive PIB binding at time 1, meaning that they have discernible levels of beta amyloid in the brain, and over time, their performance on this memory task uniformly declines. And for the converters, represented in the green line, who were negative at time 1, but converted to PIB positive at time 2, they also declined in memory performance. So the aims of the current study were to demonstrate a relationship between executive function decline in Down syndrome and increased beta amyloid load, as well as to identify the neural correlates of executive function in people with Down syndrome. The data comes from the Alzheimer's Biomarker Consortium in Down syndrome, which is a 5-year study of 600 adults with Down syndrome across 18 sites in the United States and 1 in the UK. 41 participants completed all of the procedures at 2 time points that were 16 months apart. These procedures included PET scans, MRI, 5 executive function tests, and their Alzheimer's disease status was determined at both visits, also through a consensus conference process. So we compare the longitudinal changes in beta amyloid to executive function performance, irrespective of age or AD status. The mean age of our adults were 51 years old, more than half were males, and approximately half were cognitively stable at cycle 2, and half had substantial cognitive decline by cycle 2. All of our participants had lifelong intellectual disability, and vast majority were in the mild ID range. So we used 5 different tasks to measure various aspects of executive function. The first is a cancellation task that measures visual scanning, selective attention, and speed. Participants are given a page where they have to mark off the intended target. For example, a house, and they are to cross off all the houses as fast as they can. The score is based on a combination of time to completion, the number of hits, and the number of misses. The cats and dog task uses a Stroop paradigm to measure response inhibition. On this task, participants are first asked to name all the animals, that they see in order. The task of interest is the one in which they have to inhibit that response and say the opposite of what they see. So every time they see cat, they are to say dog. And when they see dog, they're to say cat. Digit span forward comes from standardized intelligence battery. Participants are asked to repeat verbatim a series of numbers that they hear auditorily. And the modified mini mental status exam concentration score was used to measure working memory. In these series of tasks, participants are asked to count from 1 to 30, say the letters of the alphabet and the months of the year in order. And the verbal fluency task measures semantic fluency by having participants name as many items of clothing, food, or animals as they can in 20 seconds. So for the regions of interest that we examined, we made sure that we looked at least one area within each part of the cognitive control network. We co-registered our PET data with our T1 weighted MRIs, converted them to standardized uptake value units using the cerebellum cortex as the reference region. For whole brain comparisons, we use linear regression models controlling for time between scans, maleness and femaleness. For voxel-based analyses, we had our MRI images warped to a Down syndrome template. And for our region of interest comparisons, we used mean SUVR values from an atlas region from FreeSurfer, looking at these areas: the anterior cingulate cortex, anterior insular cortex, dorsolateral prefrontal cortex, inferior frontal junction, and posterior parietal cortex. None of our whole brain amyloid comparisons were significant. There were some trends, as you can see here, as beta amyloid increases, performance on the task decreases. Since the cancellation task is predominantly dependent on the time to completion, a higher score indicates worsening performance. However, none of these comparisons were significant at p less than 0.05. And the same is true for these other tasks. For our voxel-based analyses, we did find more relationships. For example, on this cancellation task, increased burden in the frontal superior and the precentral areas were significant at the 0.01 level. However, that was for the uncorrected level. None of our comparisons survived the higher threshold using the false discovery rate. And same thing here for cats and dogs task. We found significantly more relationships as well as, and those relationships were also significant at a higher threshold of p less than 0.001. Same for the digit span forward, we only found one significant relationship, and it was in the temporal lobe. And here for the MMSE concentration, there are a number of significant associations, as well as for verbal fluency. And so this heat map summarizes the findings across all 5 tests. Each area of the cognitive control network was associated with at least performance on 1 or more tests. But again, these longitudinal increases did not survive the higher threshold of after controlling for multiple comparisons. So we looked at effect sizes given our relatively small sample size. For your reference, effect sizes 0.5 and greater are considered medium. 0.5 to 0.7 are considered to be medium, and effect sizes 0.8 and greater are considered to be large. And so you can see that we had several effect sizes that were quite large, especially for the cancellation task. And these associations were also related to multiple regions of interest, not just a singular area. Our region of interest analyses were not significant after correcting for multiple comparisons using the Hom correction, but several of the relationships were significant and corrected. The only regression model that was significant with the correction was the cats and dogs test and burden of increased amyloid in the occipital lobe, which was not one of our hypothesized regions. So in summary, executive function decline in Down syndrome is more closely related to regional changes in amyloid burden than global changes. Voxel-based amyloid increases in the 5 different areas of the cognitive control network that we looked at were associated with executive function decline, adjusting for the same covariates as the whole brain analyses. And the neurocorrelates of executive function in Down syndrome is similar to that in the general population, despite the fact that people with Down syndrome have atypical brain development, lifelong cognitive impairments, and long-term AD pathology. There's a couple limitations to the study. First, our sample size was smaller than expected due to the pandemic, which limited our ability across different sites to bring people in for testing and scanning. As a result, we had less than half the number of, we were able to perform less than half the procedures than we had anticipated. However, we were able to resume in-person visits and scanning by cycle 3, and we just completed all cycle 3 PET scans a couple of weeks ago. The other limitation was the changes in neuropsychological test performance were rather small over the 16-month interval. So by looking at our cycle 3 data comparing to cycle 1, we'll be able to look at change in performance over a longer interval. I'd like to thank my collaborators, as well as our funding partners at the National Institute of Aging, the National Institute for Child Health and Human Development, as well as the many families and agencies that serve people with developmental disabilities. Thank you.
Thank you so much.